The sun rises over the San Joaquin Valley, California. Today is March 23rd, 2020. We are excited to announce our new group of residents: Daniela A., Daniela V., Valerie, Namdeep, Annabelle, Ariana, Yosbel, and Ikena. Welcome to the club, doctors. This is the beginning of the most exciting chapter in your medical career. We are so thrilled to have you. I know what you're thinking. What's new with COVID-19? Well, one thing is for sure. This disease has changed the way we train as residents, the way we live, socialize, and interact with each other. On Thursday, March 19, 2020, Governor of California, Gavin Newsom, issued a statewide stay-at-home order to protect the health and well-being of our great people and to halt the spread of this devastating disease. The World Health Organization warns us about the acceleration of COVID-19. It took 67 days from the first reported case to reach the first 100,000 cases. It then only took 11 days for the second 100,000 cases, and just 4 days for the third 100,000 cases. Dun dun dun. These days, our clinics are more quiet than usual, with most visits as phone encounters. We get a glimpse of what telemedicine is all about. Our didactics are canceled, and instead, we are on self-quarantine and becoming master home test takers. Our inpatient team is working hard to care for our patients and help prevent the spread of disease. Some of us have found a new love for all indoor cooking, yoga, dancing, and being quarantined.
Welcome to Rio Bravo Q Week, the podcast of the Rio Bravo Family Medicine Residency Program, recorded weekly from Bakersfield, California, the land where growing is happening everywhere. The Rio Bravo Family Medicine Residency Program trains residents and students to prevent illnesses and bring health and hope to our community. Our mission is to seek, teach, and serve. Sponsored by Clinica Sierra Vista, we are providing compassionate and affordable care to patients throughout Kern and Fresno counties since 1971.
I know that I know nothing. Socrates. I know that I know nothing. What a wonderful phrase. We're going to try to fight ignorance again in this episode number 4 with Dr. Gregory Fernandez. He's our guest today. He's on his last months of residency training, and he's on his third year, of course, of family medicine residency. He's famous for his grilling skills. Welcome, Greg. We're happy to have you here.
Thank you very much, Dr. Yaza, for having me.
So today, right now it's about 6:20 p.m., so it's been a long day today, but I'm glad that you decided to stay and share this time with me and with everybody. So as you know, we have 5 questions in our podcast. We're going to start with our first question, which is, tell us who you are.
Well, hello. My name is Dr. Gregory Fernandez. I was born and raised in Santa Fe, New Mexico. I did my undergrad in biochemistry at the University of New Mexico, and I did my medical school out in University Autónoma de Guadalajara out in Mexico. And now I'm here in Bakersfield doing my residency as a third year here at the Rio Bravo program.
So, Greg's bio is even more interesting than that, but he decided to share just a little bit because we always get nervous in front of the microphones, so I don't blame him. But let's go to question number 2. Tell us what you learned this week, Dr. Greg.
All right. What I learned today is I would like to share with you the recommendations for diabetic management. The topics that I want to talk about today are the new recommendations for A1C screening, lipid management and screening, recommendations of ACE and ARBs for primary prevention of diabetic kidney disease, and also the new guidelines for exercise and diet.
Oh, that's excellent. So diabetes is a very hot topic very hot topic always in our clinics because we see a large number of diabetics in our population, our community. And I would like to start by talking about the pathophysiologies of diabetes, and I know that you have a very interesting approach to that.
Oh, thank you very much. Yeah, diabetic is, it's very multisystemic. The key management of type 2 diabetes is to restore and sustain the beta cell function. The more irreversible the beta cell function becomes, the more resistant the patient becomes to treatment, and the more likely a patient can require insulin. Our roles as physicians is early intervention to preserve this beta cell function. Once damage has been done to the beta cell, this damage can become irreversible and is the one reason early intervention is key. If we think about beta cell function in terms of an ejection fraction and the ability of a beta cell to secrete insulin, as the ejection fraction of the cell decreases to about 25%, our patients can then become more insulin resistant. Often we blame our patients. For instance, if our patient comes in and their A1C continues to not be at goal, despite optimizing diabetic medications, we often blame them for diet or for non-compliancy. However, these patients might be insulin resistant secondary to irreversible destruction of these beta cells. Obtaining C-peptides and HOMA-IR scores might be the next step along with consideration of starting insulin at that point.
So C-peptide and HOMA-IR. The HOMA score is just a calculation that you can use for insulin resistance. You use the glucose level with the insulin level, fasting insulin level, and you can get a score. If the score is above 2, usually patients have insulin resistance already. But you can also diagnose that as with a clinical exam. If a patient has, for example, acanthosis nigricans, you can tell a patient has insulin resistance. Or a patient has difficulty losing weight. Those are other reasons to think that the patient has insulin resistance. So you have picked 3 of the most important updates that you want to talk about. So let's talk about the A1C screening recommendations.
Okay. Yeah, so the A1C has now been approved for diagnosis of diabetes. However, hemoglobin A1Cs does have its limitations, including hemoglobinopathies such as pregnancies, sickle cell anemia, hemodialysis, hemolysis, and transfusions. These can all alter the hemoglobin A1C levels. Hemoglobin A1C, as you know, is part of the hemoglobin family and things that can alter hemoglobin levels, while they can also alter hemoglobin A1C levels. It's acceptable to measure A1Cs biannually, meaning every 6 months. If the patient is meeting treatment goals or glycemic control is stable, then I wouldn't have to see this patient for 6 months, and at that time I'd repeat his A1C. However, if the patient is not meeting treatment goals, or if I change medications during this visit, I should follow this patient up in 3 months, and at that point it'd be appropriate to reorder the A1C during that visit. Once the patient is diagnosed with diabetes, it's never appropriate to follow the patient in 1 year. You should always see your diabetic patients at least every 6 months. So basically, if they're meeting treatment goals and I'm changing no medications today, I'll see them in 6 months. However, if they're not controlled and or I'm changing medication regimen today, then I'd go ahead and follow them up in 3 months. It's also appropriate if you're concerned about anything in particular, you can follow them up in shorter intervals.
Okay, so that's important to remember. At least every 3 to 6 months, or more often if needed. So A1C has its limitations, but so far it's the most useful tool that we have in the clinic to assess the response to treatment. And you have to take those things into consideration as you said. So lipids. Lipids is always a hot topic because we know that statins are always considered a very good medication to lower cholesterol and to lower morbidity and mortality caused by cardiovascular disease. So give us some updates or some information about lipid management in diabetes.
Sure. So it's always order your lipid panel at time of diagnosis of diabetes. If the patient has no previous diagnosis of either diabetes or hyperlipidemia, you can order the lipid panel every 3 to 5 years. Otherwise, healthy individuals with normal BMIs, you would screen these according to gender. Men are screened at age 35 and women at age 45. However, if previous diagnosis, you can order the lipid panel yearly. If hyperlipidemia, if you're initiating treatment or you're changing their therapy, then it's also appropriate to order the lipid panel every 3 months. When determining moderate versus high dose intensity statins, this in part can be determined by the atherosclerotic cardiovascular disease score. If the 10-year risk of atherosclerotic cardiovascular disease is greater than 7.5 and the patient's aged between 40 and 75, this patient would warrant a high-dose statin. For example, atorvastatin of 40 milligrams or 80 milligrams is considered a high-dose statin.
And what do you think were people between 40 and 75 years so chosen to measure the need of high-dose statin based on that score in the ASCVD score?
It was because this was the mean age of the study population that was studied. This doesn't mean that a patient that's younger than 40 or older than 75 of that age do not benefit from statins. However, despite age, it's appropriate to dose statins based on tolerability. Usually, patients over the age of 75 do not tolerate high-dose statins secondary to myalgic side effects. In these cases, moderate dose statins are acceptable. For that matter, it is always appropriate or important to dose statins as maximally tolerated.
Excellent. So yeah, statins are always a big topic because basically all diabetics older than 40 years old should be at least in a moderate statins. So that's good to remember. Are there any other times when you think high-dose statins can be required?
Yes. If LDL levels are greater than 190 milligrams per deciliter, you can start high-dose statins at any age, or if the patient has a history of a stroke or a heart attack. However, if a patient without a 10-year risk of atherosclerotic cardiovascular disease and it's less than 7.5 and they're between the age of 40 and 75, it would also be appropriate to use a moderate intensity statin in these patients. But it's also, you need to keep in mind with all statin therapy, it's also important for lifestyle modification.
So yeah, statins always work better, like any other medication, with lifestyle modifications. That's very important. Tell me the recommendations, Dr. Fernandez, about ACE and ARBs for primary prevention of diabetic kidney disease. And this is very important because we hear this all the time.
Yeah, this is true.
Yeah.
So the new guidelines, they say it's not recommended to start ACE or ARB inhibitors if the patient is diabetic with normal blood pressure, and it's also not appropriate to start a diabetic on an ACE or an ARB inhibitor if they don't have microalbuminuria. However, it is appropriate to start a diabetic patient if either elevated blood pressures or microalbuminuria, or including the combination of the two.
Okay, so ACE or ARB. So it's important to say ACE or ARB because they shouldn't be on both. And that's very important to remember too, because the combination of the two can increase the risk of actually kidney disease. So now we're going to talk about this very important topic. It's one of my favorites because we normally want to counsel our patients to exercise and to lose weight. But give us some guidance about that.
Yeah, so the current exercise guidelines are recommending a minimum of 150 to 300 minutes per week of moderate intensity exercise, or about 30 minutes 5 days out of the week. The reason that the guidelines are written so vaguely, 150 minutes per week, was to allow our patients to manage their own time, and they found that it would increase the patient's compliance to exercise.
Okay, and so there is also some guidelines about weight loss. So tell us about the weight loss.
Yeah, the new guidelines. A healthy weight loss is to lose about 7% of your current body weight within 6 months, or at a pace about 1 to 2 pounds per week. This translates to decreasing your calorie intake by about 500 to 1,000 kilocalories per day, which is estimated to be about 1 portion of food per meal. Dr. Arias, I was told that the new sitting is now the new smoking. We spend about 75 to 95% of our days sitting either at the computer or at a desk. We drive home, we sit down while we eat, charting and watching TV. It's important for us as providers to titrate exercise and to not induce harm in our patients. If we take our patients who live a sedentary lifestyle and we start them on exercise, we can actually induce harm and cause them to have a stroke or a heart attack. The guidelines for the exercise, just as a rule of thumb, it's really hard to explain to a patient how to titrate exercise or what moderate intensity exercise really is. But basically, there's 3 types of exercise as far as intensity goes. There's a low intensity, a moderate intensity, and a high intensity. And just as a rule of thumb, if you're in a low intensity exercise, you should still be able to talk and sing. If you're in a moderate intensity exercise, you would most likely be able to talk but not sing. And if you're in a high intensity exercise, you would most likely not be able to talk or sing.
That's interesting. That's a good way to know how intense our exercise is. And, the 150 to 300 minutes is very important to remember, because you can guide your patients in a better way if you give them a specific number. And it's important to do what you said. It has to be a gradual increase in exercise or in physical activity. Patients usually don't like the word exercise, so it's better to use the word physical activity. 150 to 300 minutes a week of moderate exercise. And it should include also twice a week balance or weightlifting or strengthening exercise. And that's also included in the guidelines. So tell me something more about exercise.
Well, Dr. Diazzo, the good part of exercise is once you start, it's very addictive. Exercise, it releases a lot of neurotropins, including norepinephrines, dopamines, and serotonins. Serotonins increase motivation in patients. It helps with their depression. Norepinephrines increases the memory of our patients and the attentiveness of our patients. And dopamine, that just makes people crazy.
Yeah. So I'm still waiting for that addiction to happen to me. So I hope that's a kind of addiction that I want to have, be addicted to exercise. So what do you think is important when you teach your patients about exercise?
Yeah, it's important for us as providers to put on our coaching hats instead of our dictator hats when we discuss exercise with our patients. We often request our patients to walk or to run, but what if a patient enjoys hula hooping or walking their dogs? We often think of exercise as an individualized or self-centered activity. What if we could incorporate our family time? Grandparents playing with their grandchildren, or married couples bonding with their children, encouraging healthy families. Does it really matter what activities we're doing, or is it more important the act of activity? Studies have shown that if we encourage our patients to do exercise that they enjoy, this increases their compliancy.
Yes, enjoyment is very important for exercise. If you enjoy it, you are going to be more likely to follow that exercise plan. So that's very good. And so now that you shared this knowledge with us, it's very good. I'm very thankful that you came to talk to me today. And tell me, what do you think this knowledge is important for you and your patients?
All this knowledge is important because I've used it in my own practice, and I find that it can bring out a lot of humor, a lot of interactions with your patients. They seem to be more compliant. And it gives them a way to understand what we're talking about as physicians and our goals for them. And so I've really enjoyed incorporating all these guidelines into my practice.
Yes, and diabetes. Diabetes is so common in our clinic, right? So I don't know, 80% of our patients, they have diabetes or they have a weight problem. It's very rare to find a patient that has normal BMI, to be honest to you. So I'm glad that you are bringing those guidelines to the table today to talk about them. And tell me, how do you get this knowledge, brother? Well, you're my brother too, but you're Dr. Fernandez.
Yes. I got it. I went to a conference out in Boston, Massachusetts. It was through Harvard University, and the conference was called Diabetic Up to Date 2019. It's a conference that happens every year. It's a very informative conference. I recommend it to anyone who wants to go to the conference. I learned a lot. It's a 4-day conference. It's really intense, but I learned so much.
So, in all these guidelines, where do you find them?
These guidelines you can find on the ADA Diabetic Association.
Yeah.
So a lot of these guidelines were taken from the conference itself.
Okay, so these standards for medical care that are published every January. So we have new guidelines, and we're going to have time to review those too, and you can find the link in our website. And so diabetes is a never-ending story. So make sure that you stay up to date with all the guidelines, and I'm thankful for Dr. Fernandez because he was willing to stay with me today and share this knowledge, and I hope you enjoyed it. And remember, diabetes, you need to treat it. Yeah. See you soon. Bye-bye.
Speaking medical. The medical word of the day is transient lingual papillitis. Transient lingual papillitis is a common, short-term, painful inflammatory condition affecting one or several fungiform papilla on the tongue. The condition became known as lie bumps after the myth they were caused by telling a lie. They are actually caused by local injury or aggravation to the tongue. This can be in the form of hot or cold foods, spicy foods, acidic foods, too much sugar, inflammation and stress, burning and biting injuries, GERD, even viruses. You get the point. The word transient suggests that the condition only appears for a short period of time, hours to days, and resolves by itself without any treatment. While it's common, this condition often goes undiagnosed. There are no treatments that have been proven effective. By the time you are in so much discomfort, you actually want to do something about it. The transient lingual papillitis has probably already gone away.
Hi, my name is Dr. Manuel Tu Jr., and I am a family medicine first-year resident. The Spanish word for today is soplo, and soplo means murmur. Sometimes patients will come to the clinic that previous provider, like a doctor or a nurse, told them they have a heart murmur during a routine exam. Patient will say something like this: Doctor, yo tengo un soplo. Heart murmur, or soplo, is an extra sound that doctors or nurses hear when they listen to the heart with a stethoscope. Murmur is a direct result of blood flow turbulence, and consequently, the intensity of a cardiac murmur depends on the size of the orifice or vessel through which the blood flows, the pressure difference across the narrowing, and the blood flow or volume across the site. Murmurs are generally the loudest near the point of origin. Evaluation of heart murmur, or soplo, begins by answering this question: is it an innocent or an abnormal heart murmur? If your heart murmur is an innocent murmur, you will not need any test. Innocent heart murmurs are harmless. They can be common during infancy and childhood and often disappear by adulthood. They are sometimes known as functional or physiologic murmurs. If you think the heart murmur, or soplo, might be abnormal, or if you are not sure, you can order a 2D echocardiogram to confirm the presence or absence of the murmur. 2D echo will also show the size of the heart chambers, how well the heart is pumping, and how well the heart valves are working. And now you know the Spanish word soplo. All you have to do is go and assess your patient's soplos.
And now, for your sanity.
Knock, knock.
Who's there?
HIPPA.
HIPPA who?
Sorry, I can't tell you that.
Why are skeletons so calm?
I don't know, because they can't move?
Because nothing gets under their skin.
Okay. Why did the MA need a red pen at work?
I don't know. To write important notes?
In case she needed to draw blood.
Now we conclude our episode number 4, a sweet refreshment about diabetes. Remember A1C checks, ACE and ARBs, lipid management, weight loss, and exercise in diabetes. This information will continue to be updated regularly, and please consult reliable sources of information such as the American Diabetes Association and the American Academy of Family Physicians to stay current with all guidelines. This week has been atypical due to COVID-19. One day we will return to normal. During these difficult times, please remember to stay safe, eat healthy, stay active, and as one of our coordinators said, when this is all over, we are throwing the biggest St. Patrick's Easter de Mayo of July party anyone's ever seen. This is the end of Rio Bravo Q Week. We say goodbye from Bakersfield, a special place in the beautiful Central Valley of California, a land where growing is happening everywhere. If you have any feedback about this podcast, please contact us by email, rbResidency@clinicasierravista.org, or by visiting our website, riobravofmrp.org/QWeek. This podcast was created with educational purposes only. Please visit your primary care physician for additional medical advice. Our podcast team is Hector Ariaza, Lisa Mandanares, Cole Rizasefi, Greg Fernandez, Manuel Tu, Gina Cha, and Monica Kumar. Audio by Siraj Amrutya.